Assalamu alaikum. I'm Dr. Matiullah. I'm consultant endocrinologist at Shifa International Hospital. So today we will be discussing about the management of thyrotoxicosis. So thyrotoxicosis is a general term for the presence of increased levels of thyroxine, T4 or T3 or both from any cause. It does not imply that the patient is markedly symptomatic or toxic. As the name indicates, thyrotoxicosis, this should not be confused with thyroid storm, which basically is an extreme level of hyperthyroidism or thyrotoxicosis. So in this, it just simply implies that the T4 and T3 are increased in the body due to any cause. But when that is due to the overproduction of thyroid hormone synthesis by the thyroid gland, then we call it hyperthyroidism. So thyrotoxicosis is an umbrella term in which any cause can result in the increase in free T4 and or T3. But when it is due to the synthesis of thyroid hormone, the synthesis involves many steps, and when that is increased, then we call it hyperthyroidism. So this is an important clinical and clinical difference, and we should be knowing this. So there are some non-hyperthyroid thyrotoxicosis and some hyperthyroidism thyrotoxicosis. The non-hyperthyroid thyrotoxicosis are basically two most important: ingestion of thyroid hormone, exogenous thyroid hormone in any form, most likely a pharmacological dose of thyroxine, which may be factitiously taken by the patient or maybe just for the treatment of hypothyroidism. And this can result in thyroxine overdose, or it may be called as drug-induced thyrotoxicosis. We cannot call it hyperthyroidism because the thyroid hormone is not synthesizing it, and we are just providing the thyroxine from the patient is just taking it exogenously. So we can't say that this is actually hyperthyroidism. It's important. We will talk about it, why it is important to know the difference. And then it can also be due to inflammation with the release of endogenous thyroid hormone. Now, hyperthyroidism, when we call it hyperthyroidism, then we know that the thyroid hormone is synthesizing it. There is increased synthesis of it. It is either antibody-mediated stimulation of the thyroid tissue, which is in Graves' disease, or it can be autonomously functioning thyroid tissue, like toxic multinodular goiter or toxic adenoma. Now, in the hyperthyroidism, the most important causes are Graves' disease, toxic multinodular goiter, toxic adenoma, and in the non-hyperthyroidism cause of thyrotoxicosis, it is subacute thyroiditis. Now, we start with this case of 34-year-old female with the history of thyrotoxicosis, was on numericazole from 2018 to 2021, but not taken for the last 1 year and not done any scan in the past. She complains of weight loss, tremors, fatigue, palpitations, heat intolerance, and on examination, mild tremors and tachycardia. There are mild eye signs, that is the periorbital swelling, but no exophthalmos or lid retraction or chemosis. The clinical activity score of 1/7 and mild severity of Graves' ophthalmopathy. Now, you can see we have to tell exactly the two important parameters whenever we are describing Graves' ophthalmopathy. One is the severity, whether it is mild, moderate, or severe, or even it can be sight-threatening, in which the cornea is involved or the optic nerve is involved. So this is the severity. But then we also have to tell about the activity, the inflammation. Inflammation, we know, redness, swelling, pain, all these signs are of inflammation. It's important to tell both things separately because we actually give the steroids, IV pulse steroids, when the patient has acutely inflamed thyroid eye disease or Graves' ophthalmopathy. If the clinical activity score is 3, 4, then we will be treating with IV methylprednisolone. But the severe eye disease, which is not active, which is not inflamed, will not be treated with IV steroids. Instead, we may go for the surgeries and other procedures. So this was just an additional point which I wanted to make. On further examination, the neck is diffusely enlarged, thyroid gland is non-tender, firm in consistency, moderately enlarged, no nodules palpable, and there is no retrosternal extension. So here you can see there is mild periorbital swelling, but there is no exophthalmos, or there is just mild exophthalmos with no lid retraction. And there is no chemosis. The clinical activity score was 1/7. There is diffuse goiter. Here you can appreciate the lab test done for this patient shows a TSH of less than 0.01 and a free T4 of more than 7.7. Now, this patient has markedly severe thyrotoxicosis, and it is likely due to Graves' disease. There is increased synthesis. So we will call it Graves' thyrotoxicosis or Graves' disease. And now we can confidently call it as a hyperthyroidism case. So hyperthyroidism, the key point is that thyrotoxicosis not always reflect endogenous hyperthyroidism. Graves' disease is a clinical disease, clinical diagnosis, but when we are unable to diagnose it, then we have to do thyroid uptake study, which is the thyroid scan, the technetium-99 scan, to distinguish between hyperthyroidism or non-hyperthyroid thyrotoxicosis. Non-hyperthyroid thyrotoxicosis is either thyroiditis, which may be painful or painless, or it can also be due to ingestion of thyroxine hormone. And in the hyperthyroid, we know either it is Graves' disease or it is nodular goiter, toxic multinodular goiter, toxic adenoma. And how to treat it? Now, my main focus will be on the treatment. So there are three main treatment modalities. Antithyroid drugs, that is the numercazole in most cases, which is available in Pakistan. That is the carbimazole, the trade name of numercazole. In US, it is by the name of methimazole. So methimazole is actually the active form of carbimazole. 10 mg of carbimazole will be becoming 6 mg of methimazole. Other than that, in few cases, we do use PTU, propyl thiouracil, but that is just in few cases, like in thyroid storm or in the first trimester of pregnancy, we use that. So although historically in US, most of the patients have been treated with radioactive iodine therapy rather than long-term ATDs or surgery, but there is a growing trend of a percentage of patients and clinicians that they are choosing the long-term antithyroid drugs. In UK and Japan, in Latin, they have been using ATDs, antithyroid drugs. So basically, how effective are ATDs? Now, the first question is, do the patient become euthyroid? How many of them become euthyroid? And the second question is, how many of them will go into remission and long-term remission? So whenever we start the patient on carbimazole or numercazole, we know that most of them, 90% of the patients who take ATDs become euthyroid in few months and without any significant side effects. So this is a good news. But the problem is that it needs a long-term treatment of around 12 to 18 months in adults and around 36 months in children to attain a remission. And for a long-term remission, there are around 30 to 40% chances to have long-term remission. Because when you stop numercazole, there is this recurrence of Graves' disease. And this should be kept in mind, and the patient should be educated about it. But initially, we do start a Graves' disease patient in most cases with antithyroid drug, and most cases that is carbimazole, numercazole. And in US, it is methimazole. But then after a long-term treatment, initially it will be high dose and then will be maintained on 5 to 10 mg. And after a long-term treatment, we will be actually then stopping the drug, but counseling the patients that the patient may have a recurrence of Graves' disease because it is an autoimmune disease and this drug was just suppressing it and suppressing the symptoms, suppressing it clinically, biochemically, and to some extent immunosuppression of the autoimmune disease. but we do know that around 30 to 40% will maintain a long-term remission, and the remainder will experience a recurrence. And in that recurrent case, we have to go to the definitive therapy, that is the radioactive iodine therapy in most cases, and in some cases, surgery. Now, toxic multinodular goiter and toxic adenoma, which is the autonomous functioning thyroid nodule, are not autoimmune. They are autonomously secreting thyroid hormone. So the drug, the ATDs, cannot, the patients will not go into remission. It will just maintain them. We have to maintain them on a dose. And if we stop, we know that 100% of them will recur. So what's the best way to go? We have to render the euthyroid and then go to the definitive therapy, that is the surgery or radioactive iodine therapy, depending on how big the nodules are. So carbimazole is rapidly converted into methimazole in the serum. 10 mg is converted into 6 mg of methimazole. So American Thyroid Association guidelines basically suggest that around the carbimazole dosing should be in from 10 to 15 mg if the free T4 is 1 to 1.5 times the upper limit of normal. Upper limit of normal is around 1.7 in our labs. So if it is 1 to 1.5 times of that, that is around 2.8 free T4 or 3 free T4. So we can easily manage that with initial dose of 15 mg and then 10 mg and then the maintenance dose of 5 mg. If the initial free T4 is 1.5 to 2 times the upper limit of normal, that is around 3.5, 4, then we have to give a moderate dose, which is 15 to 30 mg of carbimazole, which is numortazole. If it is increased 2 to 3 times the upper limit of normal, that is the free T4 absolute value is 4, 5, or 6, then we have to give 40 mg, 50 mg, or even in some cases initially 60 mg. This is a rough estimate. If the free T4 is 1.8 to 2, you have to give 10 mg of numortazole once daily. If it is 2 to 2.5 mg, then 15 mg of numortazole once daily. Remember remember that numortazole, carbimazole has a thyroid half-life of 20 to 24 hours. So you can give it once daily. But as the dose increase, like for example, 2.5 free T4 to 3, which requires 20 mg total dose, then it's better to split it just because of the number of tablets. Otherwise, if the patient can take 20 mg at once, we can give that. And then if the free T4 is further increased from 3 to 4, then the patient will require 30 mg total, and that will be basically 15 mg in the morning and 15 mg at night. If it is further increased to 4 to 5 free T4, then obviously 40 mg or 50 mg will be needed. In our patient, it was more than 7, so 60 mg, that is 20 mg thrice daily, or you may be going to 30 mg twice daily. As you know, सिर्फ आपने ये चीज देखनी है कि tablets ज़्यादा लेने पड़ रहा है. Otherwise, it has a 24 hours thyroid half-life. The serum half-life is around 8 hours or 6 hours. That does not matter. But the thing that matters is that numortazole has a thyroid half-life of 24 hours. You can give it once daily. But सिर्फ वो गोलियां जब ज़्यादा हो जाती है तो उसको split करना होता है. So what are the side effects associated? Usually, generally, it is safe. But agranulocytosis should be counseled. The patient should be counseled whenever you start on anti-thyroid drugs, especially when it is high dose of 40 mg and 50 mg. You should counsel about agranulocytosis. But it is rare, and it is also life-threatening. So around 1 in every 500 to 900 patients treated with anti-thyroid drug usually develop in the first to third month of therapy of anti-thyroid drug. And it is really dependent on the dose. If it is high dose of carbimazole, the patient will have high chance of developing agranulocytosis. So the patient should be instructed to promptly report any high-grade fever, sore throat, or any other infection that does not resolve, which basically means the patient's ANC count, absolute neutrophil count, is less than 1,000. That's why this is the reason that the patient is not recovering quickly from the minor infections. And the patient has severe sore throat with high-grade fever. So whenever the patient comes with these symptoms, we have to do CBC. And even before that, we should counsel the patient. Whenever you have fever, high grade, or sore throat, you should do the CBC. If the CBC is normal or it is just mildly decreased neutrophil count, you may continue it. But if it is really agranulocytosis, you have to stop the antithyroid drug. And if it is due to pneumocazole, you should not even try the PTU. Then the next is hepatotoxicity, which is usually with the PTU. But cholestatic jaundice may be with methimazole, that is the pneumocazole. Now, we have to counsel the patient. And if the patient has any fever or which is low-grade fever, basically right hypochondrial pain, anorexia, jaundice, or in a cholestatic jaundice, we know that the patient may have new onset pruritus. So the patient should do LFTs at that time. Prophylactically, doing CBC or LFTs will not change the course. Agranulocytosis occur suddenly. You may do the CBC today, it will be normal. After 2 days, the patient may develop agranulocytosis. So you cannot predict it with doing routine CBCs, and you cannot predict the cholestatic jaundice with routine LFTs. That's why जब symptoms होंगे इन दो चीजों के, तब उनको CBC या LFT करना है. The other common side effect is rashes. It is in 2% of the patient. It's more common with PTU and with higher doses of pneumocazole. And this may range from simple erythema to exfoliative dermatitis. And you may use the other drug if it is due to pneumocazole. You may use PTU, but there is 50% cross reactivity. And the patient may also complain of some joint pains, and in some cases, the patient may develop lupus. It is very rare. And remember that it is potentially teratogenic because of the methimazole embryopathy. So that's why in the first trimester should use PTU, but PTU cannot be used for long because of the risk of hepatic failure, hepatic necrosis. Okay, so baseline labs, we do the CBC and LFTs, and then whenever the patient has symptoms, we repeat them again. Now, when the patient is started on antithyroid drug, we should remember that we have to adjust the dose. If the patient is even started on 40 to 60 mg, you should again do the free T4 and total T3 after 2 weeks to readjust the dose. You cannot give a high dose for a long period of time because of many side effects. So therefore, after 2 to 3 weeks or 2 to 4 weeks, you should repeat the free T4 and T3. And remember, TSH may remain suppressed for several months, for 6 to 8 months. So you are not going to follow the TSH for your dose adjustment. That will be a big mistake because TSH बाद में भी 0.01 होगा और free T4 normalize होना शुरू हो जाएगा. The dose should be reduced at that point of time by 50% if the free T4 is normalized on your dose. So because हमने हाई डोज से स्टार्ट करके आहिस्ता आहिस्ता उसको कम करते रहना है और फिर एक मेंटेनेंस डोज पे लाना है. Thyroid test should thereafter be monitored every 4 to 8 weeks depending on the situation. और जब एक बार euthyroid हो जाए तो फिर we can go for 2 to 3 months thyroid function tests. And in between अगर कोई symptom होता है तो उसके हिसाब से febrile illness होता है तो CBC, और hepatic या cholestatic symptoms होते हैं तो LFTs. Now, this was about the drugs. Then we go to the radioactive iodine therapy, which is the second line therapy. So how does it work? So thyroid cells trap and concentrate iodine and use it to make thyroid hormone. Now, this radioactive iodine is utilized in the same manner as an inorganic iodine because it emits local destructive beta particles. Extensive local thyrocyte damage and ablation of thyroid function occurs over a period of 1 to 3 months. It sometimes takes 5 to 6 months as well. But most 80% to 90% of the cases become euthyroid or hypothyroid in 3 months. A typical dose of Graves' disease, because it is diffusely enlarged and there is diffuse uptake of the iodine, so you just need a lower dose, that is 10 MCI. But in toxic multinodular goiter, because it is not diffusely, the uptake is not diffuse, that's why a higher dose is needed. Now, if you choose radioactive iodine therapy, what is the protocol that is in the American Thyroid Association guideline? Now, because radioactive iodine therapy can potentially result in a transient exacerbation of hyperthyroidism, therefore, beta blocker should be given to every patient, even in asymptomatic patients, especially to the elderly or those who have high risk, especially उनको हमने सबसे पहले बीटा ब्लॉकर देना है जिनका फ्री T4 ज्यादा हो. In addition, free T4, if it is more than 3 or even 2.5, you should pre-treat with carbimazole prior to RAI therapy. Now, obviously, it is a controversial topic, and some people will just say कि free T4 थोड़ा सा ज़्यादा है, beta blocker देकर RAI therapy करवा ले ताकि अच्छा सा uptake हो जाए. But then again, it is debatable. Usually, what the ATA suggests is that most of the patients should be pre-treated with carbimazole once the patient is rendered euthyroid. 2 to 3 days before RAI therapy, stop the numacazole, give the RAI therapy, and then after 3 to 7 days, restart it. Because इसने तो काम करने में time लगाना है. RAI therapy will take around 1 to 2 months to work properly. तो उस वक्त तक हमने क्या करना है, न्यूमरकाजोल चलाना है, and then we have to then monitor the TFTs every 1 to 2 months, like इसमें TSH, free T4 and T3 6-week intervals for 6 months. शुरू में जो है वो पेशेंट यूथायरॉयड होना शुरू होगा और फिर हाइपोथायरॉयड के बाद आपको थायरोक्सिन स्टार्ट करनी है, और ये जब बिल्कुल स्टेबल हो एक थायराइड हार्मोन रिप्लेसमेंट डोज पे, तो फिर जाकर उसको 6-week इंटरवल को आप 3 months में भी बदल सकते हो. एंड देन आफ्टर हाइपोथायरॉयडिज्म वी नो कि वी जस्ट नीड TSH मॉनिटरिंग, एंड इन सम केसेस वेयर वी हैव सम इश्यूज विद द कंप्लायंस तो TSH एंड फ्री T4. रिमेंबर, हाइपरथायरॉयडिज्म में TSH, फ्री T4, T3 तीनों चीजें करवानी होती है, और हाइपोथायरॉयडिज्म जब आप ट्रीट कर रहे हो थायरोक्सिन से, TSH इज मोर देन इनफ. इन सम केसेस यू मे डू free T4, but you don't need T3 in someone who has hypothyroidism. Now, most patients respond to RAI therapy with the normalization of thyroid function. So 80% से ज़्यादा मरीज जो है वो 3 to 4 months के अंदर completely hypothyroid हो जाएंगे और आपको thyroxine देनी पड़ेगी. This is when we talk about Graves' disease. We know that most cases of Graves' disease after RAI therapy will go into hypothyroidism. That will be called post-RAI hypothyroidism. Now, then you will be needing levothyroxine, which is not a bad drug. Numacazole के side effects है. Levothyroxine is a natural hormone, so उसमें कोई issues नहीं होंगे. Now, remember again this point कि TSH levels may remain suppressed for a month or longer after hyperthyroidism resolves. Therefore, आपने उसको interpret करने में बहुत cautious होना है, और you should be using free T4 and total T3 rather than dose adjustment on the basis of TSH. So, sometimes 6 months में भी जो है वो hyperthyroidism नहीं ठीक होता है, तो उसमें फिर एक second dose की need होती है. This is around in 10% of the patients. Now, we are done with the drugs and with the RAI therapy. Now, let's move to the surgery. When is surgery indicated for hyperthyroidism? Surgery is generally not the treatment of choice for hyperthyroidism. Now, it is most often used in someone who is symptomatic due to compression effects of large goiter, and we know कि इस पेशेंट ने जो है वो बहुत severe symptoms हो और goiter भी बहुत बड़ा हो, तो anti-thyroid drugs may not render may just render the patient euthyroid, मगर वो remission में नहीं जा सकेंगे. Huge goiters जितने भी होते हैं या जिनका initial ट्रैप स्कोर बहुत हाई हो, ऐसे पेशेंट में यूजुअली आप ATD जब देते हो तो ये सोच के देते हो कि इनको मैंने सिर्फ यूथायरॉइड करना है और उसके बाद एक डेफिनेटिव ट्रीटमेंट पे जाना है, बिकॉज ऑफ द ह्यूज साइज ऑफ गोइटर शुड गो इनटू सर्जरी, या फिर अगर सिम्टोमेटिक हो तो फिर भी सर्जरी होनी चाहिए. जब थायराइड कैंसर सस्पेक्टेड हो या कोई नोड्यूल, हाइपोफंक्शनिंग नोड्यूल हो, तो उसमें भी ऑब्वियसली यू शुड डू सर्जरी. And if in someone who is allergic or intolerant of ATDs, especially जब pregnant patient हो और allergies to ATDs हो, we cannot do the RAI therapy. That's why उन patients में हमें जो है वो surgery पे जाना होगा. Someone who has coexistent hyperparathyroidism, which is requiring surgery, तो why not do both of them together? Obviously, पहले हमें euthyroid करना होगा with drugs and then surgery. Then moderate to severe active Graves orbitopathy in patients में जो है RAI therapy is relatively contraindicated. That's why इनमें जो है वो आपको preferred एक surgery हो जाए, और इसके साथ साथ जो है वो there is another case. Some patients have a very high free T4 of around 4 or 5. You start with the ATD, the patient develops agranulocytosis or a severe drug reaction to pneumocazole, और जब उसको शिफ्ट करो PTU तो उसको भी टॉलरेट ना करे. तो ऐसे पेशेंट्स में जो है क्या करना चाहिए कि फर्स्ट गिव द पेशेंट लूगोल्स, जो कि वुल्फ-चाइकोफ इफेक्ट के जरिए जो है वो आयोडीन जाकर बिल्कुल थायराइड फंक्शन को ट्रांजिएंटली ब्लॉक करेगा. In that point of time, free T4 will normalize transiently. Remember, ये 7 days तक ये normal रहेगा. 7 days के अंदर अंदर you have to do some definitive therapy, that is the surgery. तो because after that there will be escape phenomena. इसलिए जो है वो ऐसे पेशेंट्स में भी जो कि एलर्जी टू द ड्रग हो और आरएआई कर नहीं सकते हो बिकॉज फ्री T4 काफी ज्यादा है, तो ऐसे पेशेंट्स में लूगोल्स देकर उनका फ्री T4 नॉर्मलाइज करके फौरन सर्जरी होनी चाहिए. Now, if thyroidectomy is chosen for treatment of Graves' disease, how it should be accomplished? Preparation क्या होनी चाहिए? So, इसमें जो है वो सबसे पहले we have to render the patient euthyroid with anti-thyroid pre-treatment and beta blocker. साथ साथ लूगोल्स आयोडीन मिलना चाहिए in the immediate pre-operative period, like 3 days पहले शुरू करे या 7 days पहले शुरू करे. And also because thyroid निकल रहा है तो साथ में पैराथायरॉइड के निकलने का भी चांस है. That's why calcium and vitamin D should be replaced. So Lugol is not only beneficial for making the patient euthyroid, but also वो vascularity को कम करेगा. It will decrease the blood flow and intraoperative blood loss भी कम होगा. Therefore, 5 to 7 drops of Lugol solution is given thrice daily, mixed in water or juice for around 7 to 10 days before surgery. Total thyroidectomy is the procedure of choice. पोस्ट ऑपरेटिवली जो है वो सबसे पहले कैल्शियम का क्या करना है. 2 स्ट्रेटजीज है, या तो कैल्शियम और इंटेक्ट पीटीएच का लेवल चेक करके उसके मुताबिक ओरल कैल्शियम और कैल्सीट्रायोल सप्लीमेंटेशन एडमिनिस्टर की जाए, या फिर जस्ट गिव प्रोफाइलैक्टिक कैल्शियम without calcitriol, and then after 2 to 3 weeks just stop the calcium and check calcium. ये दोनों तरीके सही है इसमें. Antithyroid should be stopped immediately after thyroidectomy in a Graves' disease patient, but beta blocker cannot be stopped immediately. Beta blocker को slowly wean off करें. And जो ही thyroidectomy हो जाए अगले ही दिन से जो है वो thyroxine should be start with the full dose, that is 1.6 mcg per kg. What is the role of iodine in the treatment of hyperthyroidism? Large या excess amount of iodine क्या कर सकता है? So it causes Wolff-Chaikoff effect, which is transient inhibition of thyroid hormone synthesis. This is called the Wolff-Chaikoff effect. However, because of escape from this effect often occurs about 10 days. तो इसलिए जो है वो iodine is generally used only after ATDs have been started, और उसके साथ साथ ताकि rapidly हम patient को prepare करें, सिर्फ उन cases में हम use करेंगे. And also as an adjunct treatment of a patient with thyroid storm. Iodine is also used to decrease vascularity of the thyroid before thyroidectomy for Graves' disease. Typical dose, as I told you, 5 to 7 drops TID. Now, we will also touch upon the thyroiditis, which is the subacute thyroiditis, also called the granulomatous or de Quervain thyroiditis. And इसमें क्या होता है कि the patient history will be most important, and examination will be important. So moderate to severe pain on the thyroid, often radiating to the ears or jaws. Usually कभी-कभी focal होता है pain और कभी-कभी spreading from one place to another, और एक prodrome of malaise, low-grade fever, pharyngitis symptoms and fatigue, followed by this thyroid pain and tenderness. It is usually considered as a sequelae of upper respiratory tract viral infection, and that involves the thyroid gland. So in addition to all these evidence of thyrotoxicosis, जिसमें free T4 ज़्यादा है, T3 ज़्यादा है, TSH कम है, clinically जो है वो और biochemically thyrotoxic है, I'm not calling the patient hyperthyroid. Remember, this is non-hyperthyroid thyrotoxicosis. इसमें ESR भी raised होगा, and we may confirm it by thyroid scan, the technetium scan, जिसमें बहुत कम uptake होगा, very low uptake or absent uptake. This is the hallmark of subacute thyroiditis. How we treat, अगर mild symptoms हो या free T4 बहुत ज्यादा ना बढ़ा हुआ हो, symptoms भी कम हो, तो beta blocker and NSAIDs. And if not responding to NSAIDs, we go to steroids. But if the patient has moderate to severe pain या फिर thyrotoxicosis symptoms ज़्यादा है या free T4 very high, you should directly start with delta-cortil, that is prednisolone steroid therapy. So beta blocker is given as needed to control the thyrotoxic symptoms, NSAIDs for mild symptoms as a first-line therapy. But if the patient fails to NSAID, then we go to steroid. Steroid directly started if the patient has severe thyrotoxic symptoms or the patient has severe moderate to severe pain. Prednisolone is started with 40 mg for 1 to 2 weeks and then gradually tapered. 40 से 30, 30 से 20, 10 एंड इन बिटवीन कभी कभी जो है वो लोअर डोज पे रिकरेंस हो जाती है थायराइडाइटिस की, या फिर स्टॉप करने के बाद रिकरेंस हो जाती है. तो स्टॉप करने के बाद हुई तो वी हैव टू रीस्टार्ट, और रिकरेंस अगर लो डोज पे हो जाए वी हैव टू इंक्रीज द डोज. So it usually takes few weeks to few months, and sometimes 5 to 6 months is taken. So usually जो है वो 1 to 2 months में resolve हो जाता है. Now 20% of the patient may even require more than 2 months of therapy. और ये वही पेशेंट्स है जो बहुत मुश्किल हो जाते हैं, बिकॉज इनिशियली हमने इतना उनको काउंसल नहीं किया होता. So every patient should be counseled properly. Now initially there will be in the a thyrotoxic phase followed by hypothyroid phase. Hypothyroid phase is usually transient, but it sometimes takes around 3 to 5 months. तो उस दौरान फिर लो डोज थायरोक्सिन देकर बार बार आपको TSH free T4 करवाना होगा. Remember, anti-thyroid drug numercazole has no role in thyroiditis. Now, there is another thing called painless thyroiditis, which may be autoimmune thyroiditis, Hashimoto's thyroiditis, or it may be postpartum thyroiditis. Now, the thyrotoxic phase usually occurs in 5 to 20% of patient, and it is for around 3 months. Usually, postpartum thyroiditis जो है वो शुरू में थायरोटॉक्सिक फेज उसका होगा. अगेन इसमें जो है वो एंटी टीपीओ पॉजिटिव हो सकता है, बट जो ट्रैब है, जो TSH रिसेप्टर एंटीबॉडीज है, वो पॉजिटिव नहीं होंगे. एंड उसके बाद जो है वो एक वापस हाइपोथायरॉइड फेज में जाएगा जो 6 मंथ्स तक रह सकता है. एंड देन द पेशेंट में डेवलप परसिस्टेंट हाइपोथायरॉइड इन 10 to 20% ऑफ पेशेंट्स, और बाकियों में वापस TSH नॉर्मलाइज हो जाता है. सो व्हेन अ पेशेंट आस्क्स यू, अ postpartum thyroiditis patient asks you during her hypothyroid phase that I have to take this thyroxine forever, so this is the case जिसमें थायरोक्सिन बंद हो सकती है बाद में. यूजुअली तो हम कहते हैं कि जी आपको जो है वो थायरोक्सिन पूरी जिंदगी लेनी है, बट ये वो केस है जिसमें वापस बंद हो सकता है. नाउ पेनलेस थायराइडाइटिस वी डू नो कि इसमें जो है वो एब्सेंस ऑफ ट्रैब है, और इसके साथ साथ जो है वो सेकंड चीज ये कि इसमें देयर इज लो अपटेक ऑन द थायराइड स्किंटिग्राफी. सिम्टोमेटिक थायरोटॉक्सिकोसिस के दौरान सिर्फ बीटा ब्लॉकर ही दे सकते हैं. So we end with this real life case. A 14-year-old female presented to the endocrine OPD with symptoms of weight loss, fatigue, tremors, palpitation, neck swelling. On examination, fine tremors, tachycardia, eyes mild severity, graves of ophthalmopathy with a clinical activity score of 1/7. Neck is diffusely enlarged goiter. So now this patient was started by some physician in June 2022 on this lab of 0.01 TSH, T4 of more than 7 and T3 more than 6 by carbimazole 3+3+3. Fair enough. The patient came after 1 month to the doctor, and the TSH was 0.05 and T4 of 1.43. Now, this is just for learning purpose. At this point of time, we all should see that T4 has normalized. Now, we should reduce the carbimazole dose by half. 50% reduction should be there. अगर 3+3+3 चल रहा था तो अब 3+2 या 3+1 काफी होगा हमारे लिए, या 2+2 काफी होगा. So 6 tablets थी वो कितनी हो जाएंगी, वो 9 टैबलेट्स थी, तो दैट विल बिकम 4. सो बट द डोज वाज नॉट रिड्यूस्ड बिकॉज उन्होंने शायद TSH देखा था. अगेन द पेशेंट केम इन सितंबर, और यहाँ पर फ्री T4 काफी लो है, T3 भी लो है. सो कार्बिमजोल को ज्यादा कम होना चाहिए था, और भी ज्यादा कम हो जाना चाहिए था, बट probably that doctor was following the TSH, which is wrong. We should not follow the TSH. It will take time to become normalized. So हमने free T4 को सिर्फ follow करना है. And guess what? In October, the patient comes with hypothyroidism. 76 ka TSH and free T4 less than 0.4. So at this point of time, carbimazole was stopped and thyroxine was started. So this is wrong. So ये तो पहले ही जो है वो कार्बिमजोल को कम होना चाहिए था. नाउ दिस इज ड्यू टू कार्बिमजोल इंड्यूस्ड हाइपोथायरॉयडिज्म. तो इसमें अब हमारे पास तो किसी भी पॉइंट ऑफ टाइम पे पेशेंट आ सकता है. फर्स्ट करें यहाँ पर आ जाए, तो हमें क्या करना है, हमें इसको कार्बिमजोल इंड्यूस्ड हाइपोथायरॉयड लेबल करके जस्ट 1 वीक के लिए ऑफ करके वापस स्टार्ट करवाना है. नहीं करवाएंगे तो ये रिकर हो जाएगा. इस पेशेंट में तो कार्बिमजोल के स्टॉप के साथ साथ थायरोक्सिन भी स्टार्ट हुआ, जो कि गलत था, जिसकी वजह से दिसंबर में जो है वो अगेन रिकरेंट थायरोटॉक्सिकोसिस के साथ. सो यहाँ पर जो है वो फिर थायरोक्सिन स्टॉप एंड कार्बिमजोल रीस्टार्टेड. सो दिस इज नॉट अ प्रॉपर मैनेजमेंट. इस तरह नहीं होनी चाहिए. इस केस से हमें सीखना चाहिए. And this patient was referred to me in January 2023 with a TSH of 0.24 and free T4 of 0.69. यहाँ पर कार्बिमजोल 3+3 शुरू कराया गया था, और आई हैड टू रिड्यूस द डोज एक्चुअली. सो इस फ्री T4 को देखते हुए तो मैंने इनको 2+0 कर दिया था. एंड देन वी विल फॉलो आफ्टर 6 वीक्स. सो व्हाट वी सी इन आवर क्लिनिक्स के सिम्टोमेटिक पेशेंट आता है, TSH कम, फ्री T4 ज्यादा, T3 ज्यादा, तो कार्बिमजोल स्टार्ट किया जाता है. पेशेंट इंप्रूव हो जाता है क्योंकि उसका फ्री T4 नॉर्मल है. TSH कम होने की वजह से कुछ फिजिशियंस क्या करेंगे कि इसका डोज या तो बढ़ा देंगे या सेम रखेंगे, जिसकी वजह से पेशेंट विल बिकम हाइपोथायरॉइड, और फिर वो कंफ्यूज होकर कार्बिमजोल स्टॉप करेंगे और फिर टेस्ट रिपीट करेंगे, तो वो रिकरेंस ऑफ थायरोटॉक्सिकोसिस होगा. सो दिस शुड नॉट बी डन. So just a recap that around 10 to 15 mg is given for mild hyperthyroidism, 30 to 40 in moderate, and 60 in severe hyperthyroidism patient. And then उसके बाद जो है वो आप 4 to 8 weeks के बाद दोबारा रिपीट करवाते हो जब तक वो euthyroid ना हो जाए. And then maintenance dose of 5 to 10 mg should be continued. Now we check after starting antithyroid the free T4 and adjust it according to free T4. Reduce the dose by 50%. Once maintenance dose achieved, free T4 and TSH are checked every 2 to 3 months. WBC कब? जब symptoms हो illness के. LFTs कब? जब patient symptomatic हो. Thank you so much for your time. I hope इसमें सारी बातें clear हो गई. Thank you so much.